Good afternoon once again from, I guess, the lounge at Dental XP. And we're going to talk this afternoon about kind of a strange name, PET, partial extraction therapy. And this is really part one of the series. And we're going to talk predominantly about the root membrane technique, the root shield technique, or periodontal ligament mediated technique. And it's a technique that's developed recently, or really come to the forefront recently, with people like Howie Gluckman from South Africa, the group in Greece who really facilitated the publication. We'll talk about them. Maurice Lama and a whole group of different people. And we're going to talk about how we use it to handle ankylosed root resorbing teeth, particularly within the aesthetic zone. Those cases where we want to put implants in, where we've got very thin labial plates of bone, and we're going to go through the extraction process. And how do we always have to compensate for that with soft tissue, with bone? And you've seen a multitude of different people on XP showing that. Or you've got vertically root fractured teeth that you've got to deal with. So these are just some of the issues. The big problem, the gray area we enter with this, is that it's technically quite difficult and we need long-term data. Right now we've got publications of 5-year data and 3-year data and some case reports up to 9 years, which is kind of exciting. So we do have data on it. And I'm not going to talk a lot about it. I'm really going to talk about predominantly the technique. Because when you look through different articles, you'll see there are different ways of doing it. And as we've looked through the process, we've tried to find the easiest, most predictable way of doing it without any repercussions. So we'll introduce the process and we'll use an external root resorption case to do it on. This one obviously is within the aesthetic zone, as you can see on the right-hand side, and quite aggressively coming in from the distal. And this, of course, is the CAT scan of it, the CBCT, and you can see the thin labial plate there, quite dense, but you can see that if we extract it, there's really no cancellous bone. You've got cortical plate on the outside, opposing essentially a cortical plate on the inside where the PDL is. So not really great area to do an extraction. So imagine taking that out. This is the length of the root and this is the part we want to keep. We'd go down the middle and take out this portion of the root that you can see over there. And then keeping where you see the red, you put an implant in. So this is kind of the aim. And of course, it's a nice idea. The question becomes, how do you do it? How do you do it effectively, rapidly, and predictably? So this is the plan based on the CBCT. And you can see where the labial plate is kept. You can see where the implant is positioned lingual to that labial plate, and of course made to be screw retained. I believe that's an important part, and given our options, I think this is the way we should handle it. So the process then, the technique. The first aspect is you want to take off the top of the tooth, the coronal aspect, the crown. We want to do this easily, and we're going to use this burr from the Brasler kit. We call it the PET 1, or they refer to it as the PET 1. And you can see this is a round-ended, and that's important, cross-cut carbide. And the round end is nice because you get no chattering as you're cutting. It's sharp, it's clean, it goes through the enamel predictably. And you end up right at the soft tissue zone where you want to be. So this is effectively what we're trying to do. You trim it off, as you can see, on the arrow. As you cut it, you're going to be left with this. Nice to see because you can see your access now to the root canal. If you look carefully, you can also see where the external resorption is taking place. So it's on the lingual distal aspect of the tooth. You could also see the root canal. So we're going to access that root canal now with the self-same burr, the round-ended cross-carbide burr. It'll go down easily. We dial back the speed a little, so we use it on lower speed when we're doing it. And we sink it down a little way into the root canal, just until you see a nice, clean, bleeding area. So this was the burr we were using first. And kind of nice because it's also got markings on it at 9 millimeters, 10 millimeters, 11 millimeters. So you can measure all of this, either directly clinically or, of course, off your CBCT. When you move then from the PET 1 to the PET 2, the second in the kit, you'll see now is a thin diamond, and we use an aggressively cutting diamond. This is Durabraze. And you see this is marked, we have 10 millimeters of diamond, then it's marked at 11, 12, 13, and 14 millimeters. And you put it next to a probe, you can see the markings. So we're used to using this with probes, so we can use probes, as we've always done, to measure things. And we can use it, again, either directly clinically, or you can do it off the CBCT. So you're going to take this burr now, and ostensibly how many people talk about it is they would like to go with this burr to the measured length of the root canal. And I would point out this is one option. We're going to show you an alternative which we believe is probably better. But this kit facilitates it very easily. So you can go down the root canal, through the apex, into the remaining bone. And then split the tooth in two. Use this number 2 burr. And you can see now you could take out the lingual aspect of that tooth very easily. Measuring from your CAT scan, or once you access the root canal, you can measure with a file. You can measure sometimes with a probe how far down it is, and you get actual measurement beyond the tactile sensation we're all used to. This, I believe, is probably the better way of handling it. That's an alternative way. This is probably the better way. Again, the same instrument, your PET number 2. And again, we do exactly the same thing. You can see where the root canal is here on your left. We're going to access this with the PET 1. You can see it coming in. You pull it out, you'll see your canal. And now, instead of just going down the canal, if you've got a CBCT, or you have some assessment clinically of what the width of that ridge is, you kind of reevaluate this and think about where you really have the bone. And if you think about it, would you really like to put your implant down along the red line, along the root canal line, or would you like to direct the apex along the green line? Same access, but coming more lingually. And that's what we believe is easier to do and safer to do. And again, we access the top with the PET1, redirect your angulation now so that you optimize your bone support. And we're doing this with the PET2 now. See, we move to the diamond. And we go down the lingual route that we were talking about. And again, calibrate yourself for your distance of these markings on the diamond, because you know where the apex of this route is. You can measure that on most X-ray, let alone a CBCT. And you know how that is recorded on your instrument, your rotary instrument. So now you're going to the apex on a lingual route. You're going to split it mesiodistally right to where you come into clean dentine and root that isn't affected. And I think it's important to use a low torque, high speed handpiece. Don't use high torque handpieces like the ones we use for drilling out the bone for implants. Use the one that you're most useful or most used to. We're used to using handpieces, and we know the tactile sensation that comes with them, and we're used to using high speed to go through dentine. So we have an awareness. So we try to use the self-same instruments that we're used to. You can also see clearly demarcated the lingual aspect that's to be removed. So we haven't really induced any heavy torsion or torque on the root at any stage, particularly when it's in one piece. This is the piece that's going to be taken out. And to take that out, think about extractions. Think about how the root is basically attached to bone. And remember, the root isn't attached to bone, except where you have bony ankylosis or active resorption where there is no PDL. But essentially what you want to do is just sever, cut these PDL fibers between the root cementum, which you see here in the orange, and the bone. These white little fibers, if you sever them, you'll be able to remove the palatal section of the root very easily and cleanly. We use a periotome to do this. Come down the lingual aspect to the full length, and then this little piece should actually peel out very easily. And as you go down, you'll see this piece becomes actually very loose. And even when it's very thin, it will come out very easily. And you want to see the apex coming out as you go through this process. And you can see the section that Dr. Salama has pulled out. So you've now taken out this lingual aspect, and you can see how nicely it translates from a periodontal probe to the root to the burr that we were talking about, the PET2. All this information available to you. Now you've got the labial aspect. So you can see the labial aspect here, right, just below the free-gingival margin. And the aim is now to reduce this to 1 millimeter above the labial bone crest. So you want to maybe 1 millimeter above the bone crest. And remember, it's higher on the proximal than it is on the direct labial, so you want to parallel that arcuate form. So this is the form that you have of the bony crest, and you're going to replicate that in the root shield, 1 millimeter above the osseous crest, and you want to leave that 1 millimeter for the connective tissue attachment to it. And you can see, when we look in from the lingual now, you can see the soft tissue, free gingival margin. You can see totally unsupported now, and you get down to the remaining root shield, which is effectively 1 millimeter above the osseous crest. So this is effectively what we want to do. How do we do this? You could see that unprotected soft tissue, and to do that you need a gingival shield, so that when you go through the process of cutting it away, the remaining labial aspect, you don't incur soft tissue damage. And so you can see how effectively this little instrument that comes in the self-same kit will deflect the tissue, keep it away from that remaining labial root shield, and you can now work on this unencumbered by having the worry of damaging that soft tissue. So how do we most effectively take this now down to 1 millimeter above the soft tissue, to 1 millimeter above the bone? And again, don't induce any torque. So we deflect the tissue, again, different armamentarium to do this, and we're going to start on this from the lingual aspect. So you see, start from the lingual. You start with quite an aggressive instrument. So this is the PET number 4. When you look at your kit, it'll be this instrument, the DuraBraze, an aggressive non-clogging diamond. All of these are the non-clogging diamonds, so that I can use it with water, and then I can actually go down slow speed and cut it actually a little dry if necessary. So large round burr, you're going to go down from the lingual aspect of this root. So we're going to start on the lingual, and you can see we kind of burr into it. And you can see not the labial, but coming from the lingual aspect of it. So if you're doing this clinically, you can see how this diamond gouges out the lingual aspect, not all the way to the labial, just short of it. As we move along, you can see how it takes us all out, moving from the lingual again. And when you're done, you'll effectively be left with a very thin labial root shield. And this is the part that you've got to gently reduce vertically to be just 1 millimeter above the arcuate form of the bone. And you can see you've got to have the instrumentation to do this. And what we like to use here is the PET5. It's an end cutting diamond. So you see, being end cutting, if we encounter the soft tissue, it's not going to do any damage. And now that we don't have a large amount or a large volume of dentine to cut away, remember we've taken most of it away with the round, aggressive DuraBraze diamond, we can do this slowly and easily with the end cutting instrument. That's over here in the kit. So this is the PET5, the end cutting instrument, and very easy to use this lightly, adeptly, so that you come right above the soft tissue, which you can move, me again, right above the bone, which you can measure at any given stage with a probe. So you know what you're doing, that this is not a blind approach. So you can see your gingival shield protects the remaining skinny part of the root shield, kind of confusing terminology, and then we reduce it vertically. And then remember, you've got a couple of sharp edges that you've got to round off. So you'll round it off from the lingual aspect, and you'll do the same with this ET diamond, which is just a fine, flame-shaped finishing diamond. And you can see it'll easily get into those areas. Do it, of course, from the lingual, from the buccal. You've got your gingival shield there to protect you. And now you've completed the process without incurring any soft tissue damage. And the key, of course, is the choice of instrumentation and, of course, that gingival shield that we do. Then, as Dr. Salama has explained, Dr. Gluckman and the group from Greece that we'll show, we actually choose to place our implant a little away from the root shield, lingual to it. And you can see this very effectively. Look how nicely this has been reduced. The soft tissue hasn't been compromised. You can use the gingival shield to look down and see what you're doing very cleanly and effectively. You can see how nicely the root shield has protected that healing environment and maintained the buccal aspect. The question then is whether you need to put a bone graft in there, or we can just leave fibrin in there, particularly if it is very stable. And remember, this is all most effectively based and made very much more common knowledge by Marcus Hertzler's group, Otto Zur, Daniel Boehmer, and the others. And this was in clinical implant dentistry and related research, and realized it was only 2013. Their histology, quite beautiful, and you can see the soft tissue, the remaining root shield very effectively, the thin bone that's been protected, and the redeveloping osseointegration on the side. Looking at it histologically, you can see this most effectively in this area here. So dentine, titanium, bone. And this is the group from Greece who now have 9 years data. And it was Dr. Siombas who apparently first brought it to everyone's attention, Dr. Mitsias, Dr. Kotsakis, and the others that we've been involved in. And you can see this was a 5-year post-loading study from about 50 patients, 46 patients, and you can see the data in the study. And quite interesting when you read through the study and you look at it, you can see some of their work. You can see the root shield over here, and you can see the periapical defect that was present beforehand. And then as you go to about a 4-year follow-up, you can see how this defect has actually followed up with bone fill and a little root resorption, and kind of nice because of CBCTs where you can quantify all this very effectively. Go through the study, which was in JOMI. Another one in the International Journal of Restorative Dentistry, Dr. Nevin's group, by basically the same group, Dr. Mitsias, Dr. Gotsakis, and others. And you'll see they show their step-by-step technique for doing the same thing. Slightly different, again, to ours, but conceptually very much the same. So, again, the implant shouldn't be placed in contact with the root shield. You don't want to dislodge it during the process of placement. You don't want to actually buffer it or move it around. And then the question again, do we need bone in here or just perhaps a fibrin clot? This is initial healing, and you can see the nice internal aspect of the soft tissue, where you can see the vascularity coming in, and then the outside, which is so nicely epithelialized and looks good. We can go ahead, we're going to do screw retain, as we talked about early on. And of course, the big deal over here is not to get any of the cement down anywhere near this area. So this is now the socket shield process at 6 months. Just look at how this area over here, the buccal eminence, the illusion that we used to talk about of having a root there, but effectively now we have a root. We have that root eminence. And this gives you quite a different aesthetic perspective when you have this buccal eminence in the area. This is what it looked like at 6 months. So let's look at a second case, also several years down the road, but just to emphasize the technique, the process, which has really become so much easier because of the new armamentarium available to all of us, and how effective it is because it's made the process much simpler, and you don't induce any unexpected changes to the remaining root shield in the process of taking out or the lingual aspect or splitting the root. So this is a second case, about the same time. You can see the resorptive process taking place in the root, but I'd like you to look at the soft tissue. Look at the rise and fall of the soft tissue from the lateral on the right to the lateral on the left. This is the tooth in question. You can see it's slightly forward of the right central. Look at the gingival zenith, how it's positioned about in the mid of the facial aspect, and it's slightly more apical to the right central. See the soft tissue, how it looks as compared to this. We want to see much the same in the final case. So we go through the process. This is just the final sectioning of the root. You can see how this is the part that will come out, the lingual, the buccal aspect of the root shield, the root membrane is still there, and you can see how the soft tissue is held out by this aspect. We can then put the implant in towards the lingual as described in the case before, and you can see When the case is finished, this is a single PFM crown. Look at the soft tissue. It looks almost identical, if not slightly better than it did before. Again, the rise and fall from your left of the screen to the right, patient's right, and then look at the soft tissue arcuate form. Most importantly, we all have these as slides, but you can actually measure and evaluate it looking down from the incisal aspect towards the apex, and you see that the soft tissue, the whole labial plate that supports that soft tissue, is kept in identical position. So we don't go through any of the process of, socket redevelopment at any stage. You can see how we made it screw retained. This one happens to be PFM. And when we look at this in general, we showed you this part one for an ankylosed resorbing root. Both of these two cases, which we happen to show, were in the aesthetic zone and very important to both these two patients. Both had very thin bone with the soft tissue dependent on that bone. And because we kept the bone and the root, we didn't have to redevelop the soft tissue in these, critically aesthetic areas for both of these two patients. And again, as we look forward, I think we are getting much more long-term data. Remember, we said there's a case that's documented nicely for 9 years, which will be 10-year data. We've got a lot at 5 years, and you've got all these people worldwide doing it. And because we made the system so much more accessible to people, I would think this is going to be a much more common procedure going forward in the long term. I'd like to thank you all again from the Lounge at Dental XP for allowing us to share your information through this forum, and appreciate how you all interact with one another, allowing us to really accelerate this learning process so effectively. Again, this was merely a brief talk on the technique for one of the aspects of partial extraction therapy. Remember, we've shown you submerged roots, we've shown you hemisections, taking out one, or root resections, taking out another aspect of different forms of root. Look forward to your interaction soon on the forum.